speaker, Dr. Neeta Deshpande. Uh, I think Dr. Neeta Deshpande doesn't need any introduction. All of us actually know her. She is the professor and HOD medicine of Dental College, Belgaum. She is the diabetologist and bariatric physician from Belgaum Diabetes Center. She has several presentations on obesity and diabetes in national and international meetings. She has many publications in peer-reviewed journals and textbooks. She is the past chairman of Karnataka RSSDI. She is the principal investigator of several clinical trials across the country. She got the oration of Karnataka RSSDI oration in 2016. She received the RSSDI fellowship in 2016. She has got the FOCP from Edinburgh in December 2016, and she is the coordinator in consensus group RSSDI ESI clinical practice recommendation for type 2 diabetes in 2020. So Dr. Neeta Deshpande ma'am, the stage is all yours now.
Thank you so much, Dr. Sigdar, for that kind introduction. And I will start to share my screen actually. Yes. At the outset, I would like to thank Dr. Bansi and team for inviting me for this prestigious conference and giving me this topic again of great importance and something that I'm very passionate about. And that is about type 2 diabetes management and do women need a different approach. In the last couple of years, a lot has been spoken actually about whether women actually need to be treated differently, whether the management is different. And a lot of data has been coming in from a long time, but yet the guideline, it hasn't made it to the guidelines. So the guidelines are still the same for everyone, despite a lot of evidence that tells us that diabetes could be different in women, or rather being different, the risk factors are different, and hence the treatment perhaps needs to be more aggressive. And we are going to see now in this lecture some of the things that are different and what we could possibly do differently to improve the lifespan, to improve the morbidity and mortality statistics of women with type 2 diabetes. I do not have any disclosures for this talk. The overview would be how is diabetes different in women, and women go through different stages in life physically, and how that impacts the management of type 2 diabetes in women. And as I said earlier, do we really need new guidelines which will tell us what we do differently for women? So women with diabetes have more to manage. They have more to manage because they have a lot of things going on along with the diabetes that they have. They probably sometimes have to grapple with adolescents, because you have young diabetics. They have to grapple with reproduction, then with menopause. So those set of problems come along with diabetes and may affect diabetes. So they already have a lot to do, lot to manage, and along with that, a chronic disease like diabetes. We also know that diabetes increases the risk of heart disease, which is the most common diabetic complication in general, by about 4 times in women, whereas it is 2 times in men. So here itself, you can see that women could die more of heart disease when they have type 2 diabetes, and the outcomes are worse. And it is actually the leading cause of death among women with diabetes. That's the heart disease part. And also, women are at higher risk of other diabetes related complications such as blindness, kidney disease, and depression. There are many studies to corroborate this. Now there are other problems now that happen, like more than 50% of women will get a UTI in their lifetime, and the risk may be higher if diabetes coexists. So this again is going to have a lot of problems, and this is going to have also a bearing on the kind of drugs that you're going to give these kind of women, knowing this statistic. Also, we know that women suffer from PCOS, and that is a clear link with diabetes. So what can we do differently for this subset of women? Then there are changes in hormone levels, in and around the menstrual period. This again can cause problems. So do we need to look at this again differently, when we hardly ever ask a diabetic woman who walks into our office whether she's actually expecting her menstrual period or is in the middle of the menstrual period, which could be affecting her sugars. But yes, we need to probably look at that as well. Again, there can be sexual dysfunction in women because of a variety of reasons, vaginal dryness being one of them, making intercourse uncomfortable and making life a little difficult for women because of this particular thing. Nearly 42% of women with type 2 diabetes report sexual dysfunction. So these are the different kinds of problems in a nutshell, which I can say. I'm going to introduce to you some other problems also that diabetes women can have. Because of all this, look at the study. What did it say? This study found that women with type 2 diabetes treated with a structured, personalized care approach, keeping in mind all the things that I have just mentioned, for 6 years, these women had significantly better mortality outcomes than women who received routine standard care. But this was not the case for men, because probably men did not have to undergo all those different lifetime changes that a woman has. Suffice it to say here that there is proof here which tells you that women with type 2 diabetes treated with a structured personalized care approach for 6 years, they do much, much better. So that is the most important thing for us to understand out here. I'm not going to be dealing with the pregnancy and lactation part, but I will jump from preconception and the problems therein right up to menopause. So I'm going to deal with these two extremes because pregnancy and lactation are two very, very different, and that would take a long time. So I'm not going to deal with that in this particular lecture. So preconception that is there needs to be started early in diabetic women to prevent fetal loss and congenital malformations. Again, that weight loss part is there. So we have to emphasize lifestyle modification preconceptually, not just treating gestational diabetes or a diabetic woman with pregnancy. We are not going to do just that. What we are going to do is we are going to ask a person, that is the in thing now, and that is what ought to be done, that we make sure that they are metabolically normal prior to conception. So that is the way that we're going to ensure what Shalini was talking about, that we ensure all of this, that, you know, a normal fetus, a normal mother, normal next generation. So that all starts preconception. In addition to all of this, metformin and drugs that are weight neutral, such as DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, maybe we would like to use them because preconception, you want them to be at an ideal weight. So here again, you can see that the options are different when it comes to a woman, especially if she's planning conception. So different stage of life, different way of managing the diabetes. So if it is PCOS associated dysglycemia, you know that we all use metformin, and we know what metformin does for PCOS and how it is going to change the hormonal milieu. That is what we know. So what I'm trying to do is I'm just giving you a snapshot of the choices that are open to us at different stages of a woman's life when she has type 2 diabetes, and it could be different from general diabetes. You have to focus on these particular problems. So the practice calls for adolescents, girls with PCOS, or girls who are just married and want conception. Weight loss is key for them. Lifestyle modification is of course important, and the drugs that you see up on the screen there, the alpha glucosidase inhibitors, basically either weight neutral or weight reducing drugs would be ideal for them. Physical activity and the other part of lifestyle modification is of course very, very pertinent for this particular. So now I said I'm jumping to menopause because I'm not going to take care of treatment of diabetes during pregnancy and lactation, because that is something very specialized for a different lecture. So it is, let's come to menopause. Now, you know that type 2 diabetes people, majority of our population is in the menopausal age group, and this is where we have to grapple with so many different problems along with type 2 diabetes when a woman has menopause. So the factors to consider along with type 2 diabetes in women is osteoporosis and fracture risk, cardiovascular risk, as I already mentioned to you, 4 times risk of dying, depression for a variety of reasons, may be related to menopause or may be unrelated. Then rising fat and obesity. We know that as a woman ages, she accumulates more fat than a man does of the same age. And this obesity is going to worsen the diabetes problem. and then again the carcinogenic potential. So we have to deal with all of these factors when we're talking about women with type 2 diabetes who have attained menopause or are perimenopausal. So let's look at osteoporosis and fracture risk. Now look at some of these statistics which I'm going to show you. Once a woman has had type 2 diabetes for a decade, if everything else is equal, she has more than a 30% increased risk of major osteoporotic fracture and more than a 90% increased risk of hip fracture when compared to a woman without diabetes. Clearly, type 2 diabetes with women have serious problems, and they are different from women without diabetes and different from men with diabetes, and probably need to be treated as such. Now, women who have had diabetes for longer than 10 years have an elevated risk of major osteoporotic fracture that is underestimated by the FRAX tool or by the WHO fracture risk assessment. So when you assess them in the usual way that osteoporosis is assessed, you're probably underestimating the risk, and you have to keep that in mind when you're designing therapy for a type 2 diabetes woman who is perimenopausal. So PPAR gamma agonists, okay, ad hoc study in the found that there was increased fracture rates in women on rosiglitazone. Subsequent studies showed both Rosi and Pio to have a increased osteoporotic risk. Animal studies have shown that these drugs increase osteoblast activity and bone formation and increase bone marrow adiposity. What about metformin? Metformin leads to activation in bone marrow progenitor cells and primary osteoblasts and induces differentiation and mineralization. So there's evidence for all of this. Sulfonylureas are neutral to bone health. Incretins now have an important role in bone homeostasis. Vildagliptin given 100 milligrams for a year showed no change in bone markers or calcium homeostasis. These are some studies which have come up. SGLT2, no significant changes in markers of bone resorption and formation. Now, the thing is that when you look at all the clinical trials, a lot of these parameters are not studied separately in women. So we don't have a whole lot of data, but we have pointers towards it. And perhaps it is time to include many more women and study all these risk factors more in depth. And that's how we will then come out with the guidelines for women, is what I think. Now coming to the second part of it, and that is the cardiovascular risk. I already told you morbidity and mortality due to cardiovascular disease is increased in women with diabetes, and they have double the risk of recurrent MI compared to men, and CCF is also 4 times more likely in diabetic women. And 65% of diabetics die from heart disease or stroke, and diabetes increases the CAD risk 3-fold to 7-fold in women versus 2-fold to 3-fold in men. And you can see that this is all the references are there put up for your observation over here. So every year heart disease kills 50,000 more American women than men. So the data is very clear that women are suffering more if they have type 2 diabetes from cardiovascular disease, and perhaps it's time to be more aggressive. So are women with diabetes at greater risk for CVD, and why? That is the question. So studies have demonstrated that diabetes greatly attenuates or may even reverse the protective effect of female sex on the CV risk. Now, this is some meta-analysis which shows you that there's 44% greater in women, in diabetic women than in diabetic women. So men. So these are all the events that you can see. The coronary heart disease is 44% greater. And so there is enough evidence to tell us that cardiovascular diseases are more in women, more aggressive in women, causing more morbidity and mortality in women, and they are more likely to die, as I already told you. And these are all the different kinds of references and the different kinds of evidence that is available to you. This is the Framinghart study 30-year follow-up, and you can see CVD events in patients with diabetes aged 35 to 64, and for every parameter you can see that the ratio of women is much more. The risk ratio for women is much more than men. You can see it across the board of any kind of cardiovascular disease. Again, The lowest survival rates for diabetic women is what you can see. This is again a large cohort referred for coronary disease. Diabetic women had the highest mortality rates, and this is what you can see. Stratification by the number of ischemic vessels demonstrated a significant linear increase in cardiac events with escalating ischemic burden. So there is a definite skewing of the ratios in women as far as all parameters of cardiovascular disease is concerned. So multiple mechanisms may be responsible for this. It could be increase in the prevalence of classical cardiovascular risk factors, in the effects of the risk factors on development of CV disease, and so many other things. Decrease in risk factor control. There are a lot of psychosocial issues which preclude a woman getting the right kind of help and the right kind of risk factor reduction, and this also may be responsible. And it may not entirely be related to chronic hyperglycemia. There are a number of other factors such as dyslipidemia, hypertension, hormonal, genetic, environmental, etc. And as I already mentioned to you, lifestyle factors and psychosocial factors which are peculiar to women because of cultural norms and because of the cultural ethos in our country. So probably this also adds to it. These gender discrepancies increase with age and diabetes duration, exposing older women to higher CHD risk. So this is another study which talks about the gender-related differences in the control of CV risk factors in primary care for elderly patients with type 2 diabetes. And this is a cohort study. And the results suggested no difference in management of cardiovascular risk factors between elderly females with type 2 diabetes and their male counterparts. So this is a study which is telling you the opposite. So there are studies to tell you this, and there are studies to tell you the opposite. But be that as it may, there is more overwhelming evidence to tell us that it is more aggressive in women. So people with type 2 diabetes have about a 60% increased risk of dementia compared with those without diabetes. And what you find is that apart from this, the diabetes itself confers a greater risk of developing heart disease, stroke, and now vascular dementia as well in women compared with men. And you can see here that the risk was 2.3 times more, and while men with diabetes had just 1.7 times the risk of vascular dementia, and this has been published. What about the ARIC study? The metabolic syndrome severity scores increased rapidly during the transition from premenopause to perimenopause to menopause, and then slowed down during the first years of menopause. This was an analysis that was done in the ARIC study done 3 to 4 years ago. So guidelines for the use of aspirin in primary prevention, if you look at the different guidelines over the years, and if you look at all of these from 2016, you will find that there is nothing that says that anything should be, I put this just to show you that there's nothing that tells you that anything should be done differently for women, despite all the evidence that I have shown you that women suffer more. So probably it is time to change the guidelines even for primary prevention for women, instead of having guidelines which are like blanket statements for diabetic population in general. So that brings me to that same question: should we be treating women more aggressively for CV risk factors? People, especially with previous GDM, who are characterized by persisting subtle glucose abnormalities, insulin resistance, decreased adiponectin, these are the women who are at the highest risk of developing type 2 diabetes. So they should be regarded as high risk group. So should we perhaps have more aggressive CV risk reduction in them? That is the question. What about the carcinogenic potential? A new analysis from the Women's Health Initiative showed that compared with women without diabetes, adult postmenopausal women with type 2 diabetes are at a significant 13% increased risk of invasive cancer and a 46% higher risk for cancer death. Again, this brings us to the management part. We need to be careful what we are going to use. So data suggests that long-term metformin therapy may be linked with a reduced risk of cancer mortality, and this is from the International Journal of Cancer. What about TZD therapies, thiazolidinediones, and breast cancer risk in diabetic women? So this was a systematic review and meta-analysis, and this did not find a significant association between TZD use and risk of breast cancer. So there is, what I think is more studies are needed. You have studies which tell you this way and that way, but definitely more studies are needed because there is a hint of risk. What about obesity? Weight gain in women at midlife, everyone knows that. So this is a very concise review of the pathophysiology and strategies for management. So they are particularly prone to pile on the pounds at this time. And because of these unique challenges, the treatment for diabetes may have to be different. There has to be aggressive treatment of that obesity. So women with type 2 diabetes at menopause, one of the prime aims of treatment of diabetes should be weight loss with a robust lifestyle management. And you have to use drugs that are conducive to weight loss or at least weight neutral while treating diabetes. And you cannot hesitate to use structured weight loss programs. Psychosocial issues, I won't go into the details of this. Working women do not take care of themselves, secondary status in some societies, nuclear families, lot of work pressure, added burden, career priorities. So to conclude, tackling diabetes in women is a distinctly separate entity. Different phases of a woman's life dictate the therapy choices. Obesity, PCOS, fertility, CV risk, bone health, these are all special issues that need attention in a woman with type 2 diabetes. And of course, last but not the least, the psychosocial problems have to be handled adeptly because this is where the crux is, and this can be responsible for a lot of dysglycemia. So thank you very much for a patient hearing. If there are any questions, we can take them up during the question hour. Thank you.